The coronary revascularization in diabetic patient is the last presentation of this session, and I have the pleasure to introduce you to present Laura Mauri. As an interventional cardiologist, as I am really pleased to have her here because she is a reference for us. She's now in Harvard, in Massachusetts, in Boston. She graduated medicine there, also in Master in Science. He's doing interventional cardiology in Women's and Brigham and Women's Hospital, but he's the Chief Scientific Officer of the Harvard Clinical Research Institute. He's teaching also clinical trial methodology at Harvard University Medical School, and he has published a lot of papers focused on interventional cardiology from drug-eluting stents, especially in this field, but also moving to other trials like PFO trials, Mitra clip trials like Everest, all the fields of interventional cardiology, but is a really international leader in all the issues or aspects of methodology, trial design, registry analysis, especially in drug-eluting stents, but also in other aspects. Then please, you can start your presentation, and we are pleased that you could come here with us.
Thank you. That was a very kind introduction. It's really a pleasure for me to be here, an honor. And as you mentioned, I'll be moving to the more mechanical approaches to treating diabetic patients. We've heard some very refined talks about the medical treatment of patients, and I'm going to focus on what do we do when there is established atherosclerosis with significant stenoses where you are considering revascularization in these patients. And why is this important? Well, we've heard a lot about the burden of diabetes worldwide. I can speak specifically to the burden of diabetes within patients undergoing revascularization procedures. It's estimated that a quarter of the procedures performed in the United States are in patients with diabetes, and that also represents a quarter of patients with ST elevation myocardial infarction. And if you look within the patients treated with percutaneous coronary intervention, it's an even larger proportion. About 1/3 of our patients have diabetes. And the prevalence of diabetes continues to increase, 24 million in the United States in 2010. Well, I think it's quite well established that diabetic patients are different. And this is a simple summary, but we know that there is a prothrombotic and pro-inflammatory state, as you heard from Dr. Grant, that the natural history that you've also heard portends a higher rate of adverse cardiac and vascular events spontaneously. And when we do try to treat patients with revascularization, there's also a higher risk of complications and comorbid conditions. The life expectancy is decreased due to cardiovascular mortality chiefly. And most clinical studies that we have within revascularization in diabetics really have been conducted as subgroup analyses of larger randomized trials and have been relatively underpowered. So we're left with looking at the best evidence that we have and a few representative trials and others that are going forward that will guide our practice. The treatments over the years have really evolved very quickly, particularly on the fronts of both coronary intervention from a percutaneous and surgical perspective, as well as the concomitant medical therapy. And so when we look at a trial that's 10, 20 years old, we have to recognize that, that this is a moving target. And there's also a change in the pattern of what we see representing diabetes. And I apologize in advance in that most of the studies that we have looking at diabetic patients really lumped together type 1 and type 2 diabetic patients. So looking worldwide, we know that diabetes contributes to vascular events of every sort, whether it's coronary death, myocardial infarction, or stroke. And overall, vascular death is represented, about 10% of the vascular deaths worldwide are accounted for by diabetes. And so this is a significant problem all over the globe. So I will be speaking today a little bit about how indications for revascularization may or may not differ in diabetic patients from our non-diabetic patients. What are the treatment options that are available? What are the expected outcomes? And what are the ongoing areas of uncertainty? So one of the most fundamental trials that we've seen in recent years looking at revascularization was the Berry 2D study. And I'm going to go through a few clinical studies, not in order of their performance, but really in the order from the simplest patients to the more complex, because I think that may be the way that we think about this more so as clinicians. So Berry 2D took patients with essentially any reason to suspect coronary artery disease, so they did not have to be symptomatic per se, and then enrolled patients, stratified them according to whether either bypass or PCI would be the preferred revascularization strategy, and then randomized to either medical therapy or revascularization. There was a second randomization to insulin sensitization. I'm not going to focus on that. I'm going to focus on the revascularization strategies. The bottom line was that there was no difference between revascularization and medical therapy. And this may seem surprising in diabetic patients where we know that there's such a high rate of adverse cardiovascular events. But there are a few reasons potentially for this. One, this was therapy that revascularization is really targeted at treating specific lesions, and there may be more diffuse causes of cardiovascular death that may not be treated with coronary revascularization. In particular, PCI, where the treatment is lesion-based rather than more global, we may not be able to prevent later myocardial infarction. The other issue is that these patients were relatively low risk, and so half of the patients had stable angina, and 30% had no symptoms at all. So you can see that the referral patterns for coronary evaluation were probably driven by the concern for future cardiovascular events, but not really driven by what our current understanding is of treating patients with acute coronary syndromes in preference to those with stable angina, at least from the perspective of trying to prevent cardiovascular death. Certainly there are reasons to justify revascularization to treat angina, which I'll get into later. But so the combination of a fairly low-risk population really set this trial up to be an aggressive comparison to look for a reduction in mortality that was not achieved. So the COURAGE trial, obviously an important reference in the comparison of medical therapy to coronary intervention, had a sub-study that looked at those patients with metabolic syndrome and diabetes and compared the 5-year rates of death or myocardial infarction in those patients with both metabolic syndrome and diabetes or neither. And you can see that the most dramatic finding, obviously, is the difference in the overall rates. However, when you compare the randomized treatment arms of PCI with medical therapy versus optimal medical therapy alone, there was no difference according to whether metabolic syndrome and diabetes were present or not. I think the most striking finding is the high rate, 25% 5-year rate of death or myocardial infarction in these patients who were not the sickest diabetics that we see coming for coronary angiography. These patients were those with stable angina, not necessarily all with large areas of ischemia, some with relatively minor areas of ischemia who were randomized. And so this is quite a striking finding, just the observation of a 25% 5-year rate of death or MI. So I think I've shown you that in patients with stable angina or no angina, there's no mortality benefit to revascularization. There is certainly a justification, just as in our non-diabetic patients, to treat patients with angina with revascularization. But we can't say that that's a life-saving procedure. That being said, in looking at patients with acute coronary syndromes and patients with ST elevation MI, this is where we start to see real prevention of mortality emerge, just as we see this in patients without diabetes. And so this is a sub-study that was presented in the main article by Chris Cannon in the New England Journal of the TACTICS randomized trial that showed really that the largest magnitude of benefit in terms of reduction in the composite of death, MI, and repeat hospitalization was seen in the diabetic cohort. And this would go along with our observations that the overall rate in this patient cohort was higher. Similar findings have been shown in patients specifically with ST elevation MI. So to move on to the next question then, when we do choose to perform revascularization, whether it's for those patients with symptoms or those patients with acute coronary syndromes where there may be a more profound benefit. What are the treatment choices that we can compare? Obviously, PCI and bypass surgery can be compared, and they have been compared head-to-head in several trials. I think one of the most important things to recognize, though, is that the majority of data that we have has been from subgroup analyses. So although the Berry trial was really a landmark because of the subgroup of diabetic patients, this was the minority of patients who were enrolled in the main Berry study. And so if you look at the outcomes of patients at 10 years in the Berry study, you see a marked separation between bypass and angioplasty in terms of mortality. And it's remarkable that overall, the 10-year survival rate of patients enrolled in the trial was only 50%. Now, as I mentioned, this is a study that enrolled patients in the early 1990s, and a lot of things have changed since then. Medical therapy has improved, not just for diabetes, but antiplatelet therapy associated with coronary artery disease and coronary intervention. The techniques of PCI have improved. We've seen change in use of angioplasty evolve to then the use of bare metal stents and then evolve to the drug-eluting stents. And Berry was conducted in a time frame where there was still a lot of angioplasty without any stents being performed. And then bypass has improved as well, as we've recognized that importance of IMA grafting, in particular for diabetic patients. So that's important in the context of observing that large difference in mortality. The interesting finding is that even concurrently, though, in the Berry registry, one was able to examine what were the outcomes in those patients who were not enrolled and randomized in the Berry randomized trial. So these were patients where the physician preferred to send them for either PCI or bypass surgery. So there's clearly a selection bias in this comparison, and it's not adjusted for in this graph. But what one can see is that the patients who actually did undergo bypass and PCI had very similar rates of 7-year mortality to one another, whereas in the randomized trial there was this profound difference. Here you can see just how important that selection bias was, in that there was a much lower rate of 3-vessel disease in those patients undergoing PCI. Probably a very practical issue, given that the Berry trial was conducted in a time frame where there was a significant risk of restenosis in patients treated with angioplasty. Other studies that have come out of meta-analyses have been very important to understand outcomes in diabetic patients. This was published in 2009 by Mark Latke in The Lancet, and this was a meta-analysis. Here we're looking at 7,800 patients in trials comparing PCI and CABG, all patients, not just diabetic patients. And the most profound difference is not in death or death in myocardial infarction, but was in the composite that includes repeat revascularization. So this is largely driven by restenosis when one looks at the overall group of patients. And so that's obviously a more mild endpoint than looking at hard mortality. That being said, if you do look at mortality and you look specifically at the diabetic subgroup, diabetic patients do have a higher rate of mortality in these trials, 12.3% in the patients treated with CABG and 20% in the patients treated with PCI within the diabetic subgroup. And so this meta-analysis found that diabetic patients were more likely to benefit in terms of mortality with CABG. The other subgroup that was identified was patients with advanced age. Now, again, these studies were all conducted around the time of Berry or earlier, and so we're still comparing angioplasty and bare metal stents to bypass surgery, so not what our current standard of care is. Now, what about in the current era? I think this slide is very interesting. I chose to use the example of Canada, which is probably much more akin to many of the healthcare systems outside of the U.S., where there's a national health service that doesn't, so in that regard, we don't have the same influence of practice that we see in the United States. But even in this setting of national health care, one sees that over time, the rates of PCI have increased dramatically, and the rates of bypass surgery have declined. And this timing actually precedes the introduction of drug-eluting stents, but probably matches the introduction of bare metal stents. But what's, I think, interesting to our discussion today is that even in the diabetic group of patients, and this is all patients in Canada, between 1994 and 2005, there was a marked increase in the likelihood of patients being referred to PCI as opposed to bypass surgery. So patients in Canada in 2005 were 1.5 times more likely to undergo PCI as compared to bypass surgery. So why is that? Why would patients prefer to have that? This is despite the fact that one reassuring finding is that more recent meta-analyses looking at one-year mortality that incorporate a combination of drug-eluting and bare metal stents, like Syntax, show no difference in mortality at 1 year comparing PCI versus bypass surgery. That being said, we still see this 5-year difference in diabetic mortality between the two groups. And it's likely that we still don't have a complete picture because trials really have focused on some of these harder endpoints, but I think things like quality of life and patients' perception of angina, as well as the duration of hospital stay, may be the driving factors really for patients preferring to undergo PCI. And there are also new findings from more recent randomized trials, the Syntax trial, which I'll run through, that demonstrate some of the risks of bypass surgery that have been not as clear from smaller randomized trials in the past. So the Syntax trial finally is a trial that is uniquely enrolled drug-eluting stents and has now been reported through 3 years of follow-up. And the diabetic cohort was about 28.5% of those patients undergoing treatment. Patients were randomized who had either left main or 3-vessel disease to either undergo bypass surgery or treatment with a drug-eluting stent, with multiple drug-eluting stents, which were all paclitaxel drug-eluting stents. And if one looks specifically at the diabetic findings, one sees that at 1 year, actually, the results for diabetics are pretty good, in that one sees the expected rate of increased repeat revascularization procedures, which was seen in the overall cohort, but no significant difference in death, CVA, or myocardial infarction. So a similar pattern of events to the non-diabetic patients, with the exception that the restenosis rates were significantly higher. But at 3 years, the picture is not as promising. In fact, one sees an emerging difference in the composite endpoints with death, cardio. Oh. Let me see if I can go back. Just scroll back. Here we go. So one sees an emerging difference that wasn't there at 1 year between the bypass surgery and PCI arms for the composite of death, cardiovascular events, and myocardial infarction, not reaching statistical significance, but certainly a cause for concern. And if one drills down a little bit more, one can see that the biggest differences in overall MACE are driven by those patients with the highest complexity, so the highest Syntax scores, that really measure the burden of cardiovascular disease, but more specifically, the challenge of PCI in those patients. The most refined analysis was published by Michael Mack in the Annals of Thoracic Surgery very recently. And if you break down patients according to whether they have diabetes or no diabetes, and then according to their complexity, you see these three categories. It's really the diabetics that you see with the it's the diabetics that you see with the highest Syntax scores that have the most dramatic differences in repeat revascularization. They also have a difference in the composite of death, MI, or cardiovascular, CVA. It's the patients, however, with the least complex that seem to have adequate death, MI, and CVA events at 3 years follow-up. That being said, I think it's important to continue to follow these patients forward to see what the long-term event rates are. But overall, this suggests that one, like what the suggestion was in the Berry registry, one can actually select patients according to the extent of disease for what the ideal therapy would be. Now, So far, I've only shown you either randomized trials or meta-analyses based on subgroup analyses that show diabetic patients. None of these trials have been conducted primarily in diabetics. The Kardia study was designed to look specifically at diabetic patients and randomize patients to PCI versus bypass surgery. But unfortunately, it was stopped early due to funding of the study. And is relatively small and underpowered. It was also conducted in a time frame where bare metal stents were still being used, and so you can still see a marked difference in repeat revascularization rates between the two treatment arms. And so although there's no difference in death, MI, or stroke, I think that really probably the most contributory findings are still from a subgroup analyses from the Syntax trial. So now what about the impact of drug-eluting stents? We know from both observational studies that we've conducted that there's a significant reduction in TVR, that's repeat revascularization, associated with drug-eluting stents. The differences in death and myocardial infarction are probably more due to confounding rather than true differences in the impact of a drug-eluting stent to treat local disease. That being said, if one looks at death or MI in the randomized trials, this is a meta-analysis by Stetler et al. In diabetic patients, there's no significant difference in mortality or death and MI, indicating that drug-eluting stents compared to bare metal stents are safe in diabetic patients, and because of their profound impact on reducing repeat procedures are generally the treatment of choice. So you can see that treatment has evolved, and the randomized trials, other than Syntax, really haven't caught up with this evolution in PCI therapy. In addition, bypass has evolved as well. So we've come to understand the importance of the Lima graft. There's been more and more consideration for all arterial bypass. And while bilateral IMAs remain controversial, there's still a lot of debate, and I think the answer is still not there as to whether bilateral IMAs may be preferred even in patients with diabetes. The risk, of course, being an increase in mediastinitis. So I think we all are still eagerly awaiting a dedicated study with modern medical therapy, modern PCI, and modern CABG to look at patients' outcomes comparing PCI and CABG. And so the FREEDOM trial really is ideally designed to be able to answer questions that we have specific to diabetics. It will be the largest cohort of patients. It will be certainly the largest randomized trial of diabetics treated under the PCI CABG randomization, and it's designed with an important primary endpoint of the 5-year rate of death, MI, and stroke, which I think really is the critical endpoint. I think one can weigh the need for repeat procedures more critically as a secondary endpoint, because it may be something that a patient chooses to undergo, given that it's not as severe as the endpoint of death, MI, or stroke. So what are the potential trade-offs? PCI and bypass surgery over the first year tend to have similar safety. PCI has a shorter recovery time. There's also less upfront stroke risk, which was seen in the 1-year results of the Syntax trial, actually evident on their in-hospital outcomes, and better early quality of life that's also been published on the Syntax trial by Dave Cohen. But bypass surgery has a lower rate of future repeat procedures, and PCI has the downside that it obligates patients to dual antiplatelet therapy. In addition, bypass appears to prevent recurrent myocardial infarction over the long term of follow-up, and we are already seeing that in the diabetic patients out to 3 years in the Syntax study. So how do we decide today? There certainly are patients who we think have diabetes who are appropriate for percutaneous intervention, and others that we would wish to refer for bypass surgery. Some of the factors that come into play are the burden of coronary artery disease that's evident on the angiogram, whether complete revascularization is possible, and this raises a whole other set of questions as to whether it's warranted, and will the patient comply with dual antiplatelet therapy or be able to tolerate it. The reason I raise completeness of revascularization as a question mark as to whether that should be our goal is that there's more and more evidence that I don't think we've fully translated into practice yet, arising from important randomized trials. So the FAME study was a randomized trial of patients undergoing percutaneous coronary intervention, but randomized either to get fractional flow reserve measurements that interrogate the artery to see if there is a reduction in flow across a stenosis, versus just the angiographer using the angiography information to decide which lesions were significant to treat. And there was a significant improvement in major adverse cardiovascular events associated with the use of fractional flow reserve. So that is withholding treatment of those lesions that looked angiographically significant but actually did not relate to ischemia as measured by FFR. And I think this is critically important and has, at least in the United States, only incompletely been translated into practice. The FAME-2 trial is the follow-up to that study that really is in some ways related to the COURAGE trial, because the patients who are enrolled are those patients with stable angina, and they're randomized to medical therapy versus PCI. But in this case, PCI and randomization is guided by FFR. So only those patients with a significant stenosis by FFR undergo randomization. So it's a real subset of those types of patients that would have been enrolled in the COURAGE trial. And we know that from the COURAGE trial, not all the patients had demonstrable ischemia, whereas in FAME-2, they're all required to have ischemia. We can only speculate right now what the final results are, but the study was stopped early by the independent DSMB because of a positive interim analysis. And we are told in the releases that this is driven by repeat hospitalization and repeat revascularization. So I think will be controversial going forward how this will impact our care, and we hope to see these results presented soon at the EuroPCR meeting. So the indications for revascularization in diabetic patients are essentially the same as in non-diabetic patients, although one might presume that diabetic patients have a higher risk. Actually intervening earlier in the course of disease, that is those patients with stable angina or no angina, does not have a mortality benefit. And there is a benefit of treating angina, obviously in diabetic patients, just as there is in non-diabetic patients. And the same benefits in acute coronary syndromes apply to diabetics. Medical therapy is still appropriate for stable disease, and there's clearly still some advantage to treating with bypass surgery for the prevention of late myocardial infarction. Whether these differences in late events will persist now that we have the opportunity to study more modern medical therapy is really the subject of the FREEDOM trial. So I think the current approaches really have to be individualized, weighing the risks of the different complications rather than of some composite endpoint, and really require a careful discussion among the medical practitioners as well as the patient about the trade-offs and risk. And before I end, I'll just tell you a little bit about a patient that I just treated the day before I came to this conference, who asked me some really tough questions. She was a 54-year-old woman who had diabetes and had already had some complex coronary interventions performed at another hospital and was referred because of the complexity of her disease. And we used FFR to evaluate what was essentially 3-vessel disease, and had a great result treating the 2 significant lesions that she had with PCI, which was her strong preference, but I think also reasonable given her preference for being able to return to her family. That being said, she asked some difficult questions at the end of the procedure relating to what her prognosis would be, and I had to tell her honestly that the treatment that we provided would not impact her mortality, and that I was hopeful that the medical treatments that we would give her would do so, but that this was really driven by the goal of treating her angina. And I think that it's very sobering to think that the rates of death and myocardial infarction in a patient like that at 5 years are as high as 25%, and that we still have a long way to go and need a lot more study to be able to give our patients the best care. Thank you.
Any question? I have only 2 observations. I like that you started with explaining that body 2D has some limitations, because this study was seen as at the beginning of the presentation of the results, like some negative view of the revascularization in diabetic patients, and some clinicians, I think, make the misinterpretation that revascularization did not provide the expected benefit. But as you say, if you analyze in deep the study, the baseline risk is not as high as it should be. The event rate was low, 1% mortality per year, which is very low for diabetics. We have also the design of the study with the choice was done before randomization for surgery and PCI. Then you have two different strata of patients. You are comparing different things, different patients. And some conclusions were drawn from the study regarding comparison between PCI and surgery, saying that surgery is better, but really the patients were quite different with that different the extension of disease. We also have a lot of crossover, maybe 40-something% of crossover from one to the other. Do you agree that body 2D was misunderstood in some stent for many people?
Yeah, I think as always, it has a lot of information in what could be quite a simple study. So it's easy to see why it would be hard to interpret. And I think there was such an expectation, because patients with diabetes are sicker, that we might see something different. But actually the findings are consistent with what we know about coronary artery disease more generally. The fact is that if we provide, in particular, if we provide a lesion-based treatment, we're not going to change mortality or myocardial infarction for patients with stable angina. We do have an impact on patients who have acute coronary syndromes in reducing mortality, but in patients with stable angina, that focal disease treatment doesn't prevent plaque rupture in other parts of the coronary arteries. And perhaps the reason for the difference between bypass and PCI, even though they weren't compared head-to-head, but why the CABG versus medical therapy subgroup was more promising, is because bypass, avoids a whole area of coronary artery at risk rather than just the focal treatment.
And yes, one question.
Thank you. I agreed with everything you said, and I wanted to go back to the one, I think, a key slide when you showed the difference between the Barry 1 trial and the Barry registry. And in the registry, all of these were patients that were eligible for the trial, but either the patient or the patient's physician said, I don't want to randomize the patient. I'm going to treat them either with PCI or bypass surgery. And that actually tells us that the debate that people still want to have, surgeon versus scalpel versus catheter, surgery versus PCI. I have to do this debate in 2 months' time. It's completely obsolete, because what that study said was the sicker patients with more diffuse 3-vessel disease and LV dysfunction appropriately went to surgery. Many more with proximal LAD went to surgery. And what the physician did, they took out people with multi-vessel disease that had mainly 2-vessel disease, less diffuse disease. They were diabetic, and they treated them with PCI. And the end result was identical. So I think that it's not anymore surgery or PCI. It is which one for which group of patients with multi-vessel disease. And to my mind, the Syntax trial has really shown us that 1/3 of patients do well with PCI and 2/3 don't. And I think the debate's over. I don't think we should be having it, although every meeting likes to hold the debate. But.
Mm-hmm. Yeah, I agree. I think for each individual patient, one has to weigh their relative risks, and the Syntax trial really has gone a long way. Usually I don't like to look at subgroups of subgroups of subgroups to make treatment decisions, but in this case, I think, unfortunately, it's the best data that we have for diabetic patients.
In the diabetic subgroup of Syntax, we have seen that the patients with mid or low Syntax scores are doing as well as surgery with PCI. Do you believe that diabetes by itself is a factor in favoring the surgical decision, regardless of the Syntax score of the anatomic extension of the disease? Because usually in the surgical sessions of the hospital, When the patient is diabetic, always people say, no, he's diabetic, we should do surgery in this case. But the disease maybe is only 23, 24 syntactic score, is two-vessel disease, type B1 or type A lesions. I think that is more depending on the severity and extension. It's an individualized analysis of the coronary angiography that should be taken into account, not the condition of diabetics only by itself. No?
Mm-hmm. Yeah, absolutely. I think that's what that subgroup analysis demonstrates, is that the low and intermediate risk patients actually did well. They did have a higher rate of repeat revascularization, but they did not have a higher rate of death, MI, and CVA. And I think that's a conversation that you have with the individual patient. You have to tell them that you may be more likely to need another procedure in the future. But I think in particular in the context of FAME, where we may be more judicious about what actually needs to be treated, I think that should be viewed differently than the risk of future myocardial infarction. It doesn't weigh the same as a myocardial infarction coming in for a scheduled procedure.
And this given into consideration that taxus stent is no longer a top DES standard. No? I think now we have new DES that are overcoming clearly the profile of safety and efficacy of taxus. No?
Mm-hmm. Yeah, one could expect that taxus might have a higher MI rate.
Laura, you mentioned in your talk about the need for dual antiplatelet therapy with diabetics, and perhaps that being a factor to take into account. But as we all know, there are now evidence with the second generation drug-eluting stents, at least in the stable patient with stable coronary artery disease, that we may be able to reduce the duration of dual antiplatelet therapy to 6 months. Could you give us your insights into whether or not you think that that's going to be safely applicable to the diabetic patient as well, in a stable patient?
Right. I think I'll start with all patients because, in my opinion, we're not certain as to what the right duration of therapy is still, even in the overall cohort of patients undergoing PCI with drug-eluting stents. And the reason is that it's not just based on stent type, it's also based on cardiovascular risk overall. So with that, one might presume that the diabetic patients would be, and we know actually from a randomized trial that came out of Korea, the excellent trial, that the diabetic patients actually did do better with the longer duration of antiplatelet therapy. That being said, I think that what the studies so far are looking at least the randomized trials looking at shorter duration of therapy show so far, is that certainly there is a decrease in bleeding risk associated with a shorter duration, but the studies haven't been powered to see if there's an impact on either death and MI or stent thrombosis. So, as you know, we're doing a large trial that's already enrolled 26,000 patients and is in follow-up. It's an international study, and I'll talk a little bit more about it tomorrow, but that's the dual antiplatelet therapy study. We should have a sufficient cohort to understand the subgroup of diabetic patients from that trial, and I think that will be one of the more critical groups to look at first.
If there is other question over there.
Robert Dion from Belgium. I'm coming from the side of the surgeons. I think I'm going to present tomorrow the 4 years syntax trial, which is increasing the difference between CABG and PCI in some of the parameters. But what I want to say is that if you choose to operate a patient with a diabetics, you should insist that your surgeon is using arterial grafts and mammary arteries. Already in the original Barry study, the surgery was superior only if we were using arterial grafts. So first, use arterial grafts. Second, especially in diabetic disease, we should use FFR. This is what I do in my unit. Every time we have a doubt, with the visual inspection of the stenosis, we do an FFR. It's important in diabetic disease because it's usually a diffuse disease, and you can, if you use FFR, use more optimally a full arterial revascularization. So I think there are very important points to understand that surgery is sometimes superior to PCI, but in diabetics, but on the condition this is arterial grafts. And the argument of my friend cardiology is that they're not using the Taxus stent anymore, but now the X-Science or so, is also a bit countered by the fact that the surgery is also improving. When I was the head of the department in Leiden, we refused to go in the syntax trial because I saw in the room there in the Renaissance Hotel in Frankfurt too many people using veins. So the syntax trial is in fact the reflection of a mean activity in the surgical world, and I'm sure that the argument to say we are not using the same stent anymore can be answered by the fact that you should send patients to surgeons doing fully arterial revascularization, particularly in diabetic patients. And just to finish, I perfectly agree with Laura. I think we have to make our equipoise in every center with a full transparency towards the cardiologist and towards the surgeons. And I'm sure that we can individualize the treatment. I agree with Dr. Gersh as well. This sort of competition between cardiac surgeons and cardiology is over.
We are running out of time, and we have finished the session only to, as a brief summary, to say that Peter Grant has presented a comprehensive physiopathologic view of the diabetes, of the atherothrombotic inflammatory disease, from endothelial dysfunction to macrophages, thrombus formation, platelet activation, and fibrin characteristics of these patients, and remarking the important weight loss. Afterwards, Dr. Centaner has to deal with the debatable issue of the glycemic control, which is not solved yet. And he suggested that maybe we have to move very early in the disease to be effective in this regard. And finally, Dr. Mauri has also dealt with a very difficult topic because it's not supported by much evidence, which is the revascularization in diabetes, indicating the importance of individualizing the case, taking all the advantages of both techniques and giving the patient the best choice. Thank you for your attention, especially for the speakers. Thank you very much.